Good afternoon and welcome to July's OR Today webinar. Today we are joined by Robert Dybec, Nurse Manager, Operating Room at NYU Langone Hospital-Long Island, and also consultant to Ruhof. Robert has over 40 years experience in the surgical setting and has been a consultant for several companies providing education to nurses and technicians both nationally and internationally on a variety of topics. Now, OR Today would like to thank our sponsor, Ruhof. Ruhof is an innovator and leading manufacturer world-renowned for offering reliable solutions and individualized service to help you meet and exceed your decontamination and materials management challenges. Ruhof not only provides the most effective decontamination products on the market, they also allow healthcare professionals to verify effectiveness with their line of cleaning verification products. So for more information, please visit ruhof.com. Today's webinar, as usual, is eligible for one continuing education hour from the California Board of Registered Nurses, and also today one CE credit from the CBSPD. You can obtain your certificates by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your CE certificates, and you'll be able to download both certificates directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Now, just a quick reminder that OR Today is pleased to support the Southeast Councils of Perioperative Nurses Conference, which will take place in November, so that's the 14th and 15th, at the Hilton Beachfront Resort in Hilton Head Island, South Carolina. So please join perioperative professionals for CE accredited education, exhibits with leading vendors, and great networking events. For more information and registration details, please visit southeastperiop.com. Okay, let's kick off today's webinar by giving away one of our OR Today lunch call bags to the attendee that can tell me the answer to the following trivia question. July is National Blueberry Month. Which state is the largest producer of blueberries? Answer now using the question mark icon on your webinar screen, and I'll reveal the winner and answer at the end of the webinar. Now, today's presentation is pre-recorded, so there will not be a live Q&A session. But if you have any questions for Robert, please reach out to me at webinar@mdpublishing, and I will send them on to Robert.
Okay, good. Excellent. Well, good afternoon. Welcome to this OR Today webinar entitled All About Surgical Instrumentation. My name is Robert Dybec, and I will be your presenter today. Okay, why are my slides not changing? There you go. Okay, so I first want to thank OR Today for the opportunity to present once again to all my nursing and healthcare colleagues out there. This is I think the 4th webinar I've done with them. Also, a special thanks to the Ruhof Corporation for their sponsorship of this educational activity. Again, as Linda said, my background, I am currently the OR nurse manager at NYU Langone Hospital-Long Island in New York, which is part of the NYU system, where I oversee currently 5 different surgical specialties. And I am also a consultant to the Ruhof Corporation as an educator for the Ruhof staff, and also on their behalf at national nursing meetings such as AORN, SGNA, as well as other professional organizations. So let's take a look at our objectives for today. We're going to discuss instrument selection for purchase, initial sterilization. We'll describe the use, reprocessing, and reuse of surgical instruments. We'll identify methods for testing instrumentation for cleanliness. So in a previous presentation at the beginning of this year, I described the life cycle of a surgical instrument, and we will touch on many of the same topics, but we'll also dive deeper into reprocessing and address some new recommendations from AORN that will be coming soon to their guidelines for the care and cleaning of surgical instruments. So when you look closely at the life cycle of an instrument, it sort of mimics like life itself from birth to death and everything in between. An instrument is forged or created and then purchased. It is received, inspected, cleaned, assembled, sterilized, tracked, and sent to the OR to be used. In the OR, they will receive and track the instruments, then store them ready for use. The tray will be selected, tracked, and used for surgery. In the operating room, before the procedure starts, the instruments should be inspected again for function, irregularities, as well as for the completeness of a tray, looking for any missing or extra or incorrect instruments. Intraoperatively, instruments need to be wiped down with clean water by the surgical tech or the RN scrub, and immediately after the procedure. We'll talk a little bit later about the postoperative point of use cleaning and treatment with enzymatic solutions. From that point, the treated and soiled instruments will be transported to central sterile processing for instrument reprocessing. The trays will be cleaned, inspected, assembled, counted, and re-sterilized. If the trays meet all the parameters for inspection and sterilization, they will be tracked again, transported back to the OR for reuse. If any instruments fail inspection, they will be sent for repair, refurbishing, or replacement. So actually, some of you on this webinar may actually be involved with instrument purchasing. We always want to try to get the best price, but when it comes to surgical instruments, many times you get what you pay for. So some of the things you really need to be aware of are not only just price, but selection. What company are you purchasing these instruments from? What is the reputation of the company? Are they well known? Are you buying from a distributor or direct from the manufacturer? For example, are you buying instruments from a well-known company that has been manufacturing surgical instruments for many, many years, such as some of those in Germany? Or are you purchasing and getting a great price from a dealer or a distributor or even a manufacturer that's in a country not well known for producing quality surgical instrumentation? What kind of guarantees are they going to put on their product? And above all, what is the quality of the instrumentation that you are going to be purchasing? So let's delve into the quality of surgical instruments. All surgical instruments are made of some sort of stainless steel. Now, I found it very interesting as I did research about stainless steel used in surgical instruments. The name stainless steel is an American name. In Europe, stainless steel is called inox or INOX. Stainless steel only denotes steel that is corrosion and rust resistant, but stainless steel items such as surgical instruments can actually stain. They are not stainless. You may notice in your cutlery drawer at home that some of your utensils, your knives, your forks, your spoons, even after coming out of the washer, will have some water stains on them. So stainless steel is actually a mixture of metals, a type of alchemy, if you will, all playing different roles in the final alloy. The metals found in steel are pure iron, which is highly corrosive and soft and will rust very, very easily. So think of, cast iron fencing or your cast iron pots and pans that must be treated to prevent rusting. They can rust very easily. But when the iron is combined with other metals, the iron becomes one of the most commonly used industrial materials. Carbon is added to iron to give it its hardness and ductility. Ductility is what affords the steel the ability to stretch under tensile strength. That's why we see, for instance, our needle holders, our clamps are able to kind of bend and not break when we clamp them down tight. Chromium is added to iron, which adds corrosion resistance. Nickel, magnesium, silicon, molybdenum, and sulfur are residual elements and may be present in the composition. The actual degree to which steel becomes stainless is determined by all of these metals and materials. Now, most stainless steel used in surgical instruments is called 420 stainless steel. It contains carbon, but is basically 70 to 80% iron. There's a very thin layer that coats the stainless steel instruments, and it's only about 30 microns thick, very, very thin, and more fragile and easily damaged than many realize. This thin coating is the only thing that protects the steel underneath from deteriorating or corroding. Once that top layer is compromised, free iron could be released on the surface of the material, which starts the corrosion process. So what about surgical steel? So surgical steel is a variety of stainless steel that is used in biomedical applications, sometimes referred to as surgical stainless. But the term surgical steel has no formal definition of what it consists of. Only that stainless steel varieties with the greatest levels of corrosion resistance are those designated for biomedical use because they will resist highly corrosive environments such as blood, body fluids, salt solutions, cleaning solutions, and sterilization methods. Here's a photo giving some examples of some surgical instruments where that thin outer layer, that protective layer of the instrument has kind of broken down and corrosion has started. Rust is visible and the instrument itself has been compromised. Now, after the purchase is complete and all the instruments are received, they are sent to Central Sterile where they will receive them. At that point, they will inspect all of the instruments and they will assign a tracking number to the tray being created. They'll clean the instruments per the manufacturer's IFUs and then create a count sheet for the instrument tray. They'll assemble them, put them on stringers, and they will sterilize the tray and wrap or put them in canisters. Now, this initial processing is easier on the technician in central sterile as it does not involve any blood or other soil on the instruments that would need to be cleaned off. They're dealing with, brand new purchased instruments. The previous slide mentioned how the initial receipt of the instruments by Central Sterile was given a tracking barcode. So tracking is a very important part of following your instrument trays and instruments, and it has many different purposes and benefits. My hospital uses instrument tracking, and I believe that many large hospitals in the nation with large central sterile departments, they're probably using tracking now also. Now, the benefits of tracking are numerous. After assigning a barcode, which can be scanned, a tray can literally be followed along the cycle. Tracking can increase operational efficiencies, can be used for inventory management, maintenance, locating trays in the cycle as to where they are. I know personally for myself as an OR nurse manager, I'm keeping track of where trays are for upcoming surgeries, especially some of our specialty trays that we don't have a lot of. And the tracking system will literally let me know exactly where they are. So if you look at the slide here, on the initial receipt, the tray will be assigned the barcode by Central Sterile Processing Department, which can tell you at any point in the system where it is. Is it in the decontamination area? Is it in prep and pack? Is it being sterilized? Is it in the sterilizer? Is it out of sterilization and cooling on a cooling rack? Has it been dispatched to the OR? Did the OR receive it? And at all these points, that barcode is being scanned. Now in the OR, we scan it into our nurse's record of operation in Epic, so we know exactly which trays we've used on which patients. And then in central sterile processing, they'll track it when it's received back from the OR for reprocessing after use. So tracking, the ability to track your surgical instruments and trays, as we stated, has many, many benefits. So at that point, central sterile then transports the sterile trays to the operating room. Now, when the operating room receives the trays, they will be scanned in once again for the tracking system and placed in storage and ready to use for surgeries. Canisterization or replacing instruments in canisters is proven to be a much better method for sterilization of instruments than wrapping, as the paper wrapping materials from rough handling, as you know, can result in holes in the wrappers and compromised sterility. And we've seen it so many times where you're opening for a case and then you check the wrapper and there's a hole in there, and now you have an issue. Unfortunately, changing anything over to canisters could be a costly endeavor. So preoperatively, when setting up for a case, the RN scrub or the surgical technician will first look for and check the indicator in the tray, which would show that the instruments have been subject to the proper sterilization method. Further inspection would look for any irregularities on the instruments, such as staining, any rust or corrosion, pitting, damage, or foreign materials. Sometimes foreign materials inside the tray. We've opened trays and seen pens and other things that don't belong in there. Then an instrument count will be performed with the circulator and the scrub to make sure not only that all of the instruments are there, but that they are the correct instruments. Also checking the instruments for proper functionality should be done by the scrub person. So the circulating nurse will scan the barcode of each instrument tray into the nurse's record of operation. For my hospital, again, we use the Epic system, and this information is automatically populated into the patient's chart. During the surgery, if any instruments are deemed to be compromised, then the scrub will put them off to the side so that they can be tagged before sending to central sterile supply. This includes things such as scissors that may need to be sharpened or any surgical instruments that may have issues functioning. One of the most important roles of the scrub is to rinse and wipe down instruments intraoperatively with water to remove blood and tissue. Now, AORN recommended practices states that sterile water should be used intraoperatively to keep surgical instruments clean. At the end of the procedure, the scrub should wipe down and flush all instruments with visible soil and remove as much as possible. Now, this is actually the very beginning of the reprocessing cycle. So the reprocessing cycle starts in the operating room with the wiping down and then again the application of enzymatic solutions, typically a foam spray or a humectant gel that contains enzymes. These are some early photographs from my operating room. We initially began spraying our instruments with a Prepzyme foam after the procedure, and you can see in the photos how the residual blood on the instruments is already starting to break down as a result of the enzymes in the foam. Now, shortly after, we moved away from the foam and started using a humectant gel, which has the properties of keeping instruments moist for up to 72 hours. That term humectant means moist, and it's in a gel form. So this was important for us, especially because our central sterile department was not a 24/7 unit. And there was a potential that we identified for instruments to sit unprocessed for up to 72 hours if it was late at night or on weekends. This method of wiping down instruments and applying an enzymatic solution to them is known as point-of-use cleaning. Now, the enzymes in the humectant gel begin the breakdown process of the bioburden left on surgical instruments from the procedure. This is extremely important because if bioburden is left to dry on instruments, it may lead to the formation of biofilm. So after that, the OR will send the soil instruments back down to central sterile for reprocessing. So we talked about bioburden on instruments. So what is bioburden? Well, according to Ansi and Amy, a bioburden is defined as a population of viable microorganisms on a device or a surface. Bioburden can result from the contamination by, again, blood, tissue, feces, mucus. It can be found on medical and surgical equipment and endoscopes after they have been used on patients in surgical and procedural areas, as well as the surfaces in these surgical and procedural areas. Now, this gross contamination, if left on surfaces or in scopes and instruments for too long, may allow for the formation of biofilm. Biofilm is defined as an aggregate of microbes in which cells adhere to each other and/or to a surface, producing a distinct architecture. So biofilm can form as a result of bioburden not being removed quickly and efficiently and allowed to start drying. That's the key right there, allowed to start drying. So the microbes will adhere to the surface and begin to build a matrix that holds this little biofilm community together. The microbes will then encase themselves under a protective, like polysaccharide layer, and nutrients will start to feed the biofilm and allow them to proliferate. They form this little biofilm community. So what can we do in the operating room to reduce the risk of biofilm development? Okay, we said that biofilm can form as the result of bioburden not being removed quickly and efficiently and allowed to start drying. This is why we now have policies and procedures in place for the intraoperative care of surgical instruments. Wiping instruments intraoperatively to remove the gross contamination, post-procedure cleaning of gross contamination, flushing, wiping and flushing, and the application of enzymatic solutions or gels to keep the instruments from drying out before being received in central sterile for reprocessing. As we said earlier, in the operating room is the actual beginning of the reprocessing cycle. So regarding biofilm, there are 5 distinct stages of biofilm development. Stage 1 is called the initial attachment. That's where the organisms initially adhere to a surface. Stage 2 is irreversible attachment. That's where the organisms start to protect themselves under that protective polysaccharide layer. It's like a bubble. Stages 3 and 4 are the first and second stage of maturation. That's where the biofilm continues to grow and mature. And then stage 5 is a very interesting stage. It's called the dispersion stage. That's where the biofilm actually opens up to release more of the potentially harmful microorganisms that will spread and start to colonize new surfaces. So the bacteria that's growing inside a biofilm is over 1,000 times more resistant to antibiotics than the same bacteria not growing in a biofilm. This slide basically depicts the protective nature of the biofilm and how the outer polysaccharide layer will not permit antibiotics to penetrate and harm the pathogens growing inside. Bacterial biofilms are usually pathogenic and can cause persistent and chronic bacterial infections. Among all microbial and chronic infections that include hospital-acquired infections, 65% and 80% respectively are associated with biofilm formation. Now, these infections are a significant source of morbidity and mortality as the second most prevalent cause of death globally. According to the World Health Organization global estimates, 7 to 10% of patients admitted to hospitals acquire at least one type of hospital-acquired infection. And of those patients, 10% will die. In the United States, approximately 1.7 million patients develop HAIs annually. That's a prevalence rate of about 4.5%, causing more than 90,000 deaths every year. Now, surgical site infections, or SSIs, contributed to the highest proportion of HAIs, followed by catheter-associated UTIs. So we mentioned earlier about surgical site infections being the most prevalent HAI. SSIs have been associated with pathogenic biofilms, and they can present 30 to 90 days post-surgery, and it is the most common post-operative complication. SSIs develop in an estimated 2.6% of all patients who have surgery and accounts for 20% of all hospital-acquired infections. So biofilm-associated SSIs are extremely difficult to treat with conventional antibiotics, again, due to the tolerance mechanisms of the multi-drug resistant bacteria, also in the biofilm form under that protective polysaccharide layer. So if you think about it, some of these chronic non-healing wounds that we see in the hospitals, they are a result of biofilm, which even after sharp debridements, washouts, antibiotic therapy, they still remain. And when you think of the cycles of the biofilm development, unless all of the biofilm colonies are eradicated, then they may continue to repopulate the wound when they open up in that dispersion phase. Regardless of the cause or the type of infection, HAIs can have several consequences, including prolonged length of stay for patients, repeat and secondary surgeries, a decreased quality of life, increased costs, litigation, and even death. HAIs in U.S. hospitals have direct yearly medical costs of at least $28.4 billion. They also account for an added $12.4 billion in cost to society from early deaths and loss of productivity, as well as monies associated with medical legal claims. So postoperatively, the OR transports the soiled, wiped, treated instruments back down to central sterile processing department. Central sterile processing receives the instruments from the operating room, where they will be tracked, cleaned, inspected, assembled, counted, and re-sterilized. Sounds simple, right? But this is one of the most critical steps in getting our surgical instruments ready for use again. I would suggest that if possible, if you have new staff or even seasoned staff, you should send your operating room staff to the central sterile processing department for one day just to see what they do to get our instruments properly cleaned and ready for surgery. You know, when I see this slide and talk about that, I've been in the OR for a long time, and back in the day, I couldn't even imagine what Central Sterile was doing back then. What soaps were they using to clean? I don't think they even knew about enzymatics back then. Sending them down, washing them, sending them back up. But now the technology has changed, the chemicals have changed, and we're much more efficient. So the primary goal of disinfection and sterilization in the CSPD is patient safety, to provide instruments for use in patient surgeries and procedures that are cleaned appropriately, and to improve patient outcomes and reduce rates of healthcare associated infections. Now, when you think about the thousands of types of surgical instruments that Central Sterile must deal with on a weekly basis, things such as our standard instruments, clamps and scissors, delicate microsurgery and neurosurgery instruments, orthopedic instruments, cannulated instruments that require cleaning inside channels, instruments that have been subjected to all sorts of soil and bioburden. With all of these, the objectives remain the same: the removal of foreign material, soil, blood, organic matter from our surgical instruments. The purpose is because organic matter can interfere with the effectiveness of disinfection and sterilization. Dried organic material increases the difficulty in the removal process and ultimately prevents disinfection and sterilization techniques from occurring. The numerous considerations in the cleaning process and the countless steps that must be taken to ensure clean instruments is mind-boggling. Different manufacturers with different IFUs for cleaning their instruments, instruments requiring different aspects of manual cleaning, water temperatures, chemicals used in cleaning. I mean, look at this slide, which has the CDC guidelines for disinfection and Sterilization in Healthcare Facilities from 2008, showing some of the things that central sterile technicians must be aware of and must follow. Cleaning with water and detergent or water and enzymatic cleaners prior to high-level disinfection or sterilization. The cleaning solution is critical. The water temperatures and quality of the water are critical. You want to use neutral or near neutral pH cleaning materials. Common cleaners contain enzymes and used to assist in removing organic matter. Protease cleaners attack proteins. Lipase cleaners are active on fats. And you have to follow the manufacturer's guidelines in all of these scenarios and rinse thoroughly with all of these chemicals. It's just mind-boggling the things that they have to know and follow to be compliant with what's recommended by the manufacturer, by CDC guidelines, by recommended practices from AORN and the Central Sterile people, ANSI and AMI. It makes my mind kind of like shiver. To continue, the central sterile technician must also inspect for breaks in integrity that would impair cleaning and disinfection and sterilization. I mean, looking for damaged instruments, engraved instruments, difficult to clean areas. They must perform manual cleaning or mechanical cleaning based on the manufacturer's IFUs. Some of the essential components of manual cleaning include friction, rubbing, scrubbing with a brush. Flexible scopes and cannulated instruments can be especially challenging to get inside and around crevices. You know, think of your cannulated reamers in orthopedics, very difficult to clean. Chunks of bone and debris in there. And with everything the central sterile technician must do to effectively clean our surgical instruments, let's just give a shout out to them. If any of them out there, you know, I give you a lot of credit. They are an integral part of the perioperative team, ensuring that our instruments are cleaned properly and sterilized properly. Again, it's a lot more than just throwing them in a washer, stringing them up again, and sending them back to the OR. As I said, they are a key player in patient safety, good surgical outcomes, and reducing the risk of infections. Let's now discuss some methods for testing for cleanliness. So assessing successful cleaning processes of surfaces, devices, instruments in a healthcare environment can be supported by implementing contamination monitoring methods such as direct practice observation, swab cultures, agar slide cultures, ATP bioluminescence tests, and protein tests, to name a few. Now, AMI standards dictate that any test method used to monitor cleaning effectiveness should be accurate, objective, replicable, rapid, simple, and quantitative. So visual inspection, that can help when gross contamination is visible, but it's not a reliable measurement of any level of cleanliness. Visual inspection cannot detect biofilm or any unseen bioburden. Additional verification is necessary to ensure optimum patient safety, and there's multiple verification methods that can be used as an adjunct to assess cleaning efficiency. So using laboratory cultures, although it's easy and will literally provide specific data about which pathogens may be growing, it has its time constraints. It is not a quick and efficient test as we are waiting days for the results to come back. You don't want to culture your instruments and be waiting 2 or 3 days for results to come back. So agar slide cultures, although some difficulties have been encountered with utilizing agar cultures on surfaces that are kind of not flat and broad, the technique generally provides an easy method for quantifying viable surface contamination. But again, similar to the laboratory swab cultures, it's necessary to wait for results. It's not a time-efficient method. Now, ATP testing has become extremely popular over the past decade. All living cells will use ATP, adenosine triphosphate, as the fuel to drive biological reactions for cell function. Basically, it's the energy molecule of the cells. It was first discovered in 1929, and because of its ability to provide real-time results, the ATP bioluminescence method was developed and has been widely used since the 1980s in the food industry to monitor the hygienic status of food production lines and verify the efficacy of cleaning procedures. And now it's widely used in healthcare clinical settings. The presence of ATP on medical devices, instruments, or surfaces may be an indicator of residual contamination. Modern bioluminescence tests are based on the reaction of luciferase extracted from fireflies. The substrate was known as luciferin, and the reaction was known as a luciferase reaction based on the enzyme. The amount of light is emitted is called a relative light unit. It's measured in RLUs, and that is directly proportional to the amount of ATP that's basically present in the sample. So that the higher the number of ATP, the higher the number will be, and it gets a larger like light burst. The ATP luminescence test is based on the measurements of ATP present on a surface. So it will detect organic matter, but it cannot detect pathogens that cannot produce ATP, such as viruses, for example. The method is carried out by swabbing a surface, inserting the sample into an ATP test sleeve, which contains the luciferin. That reacts to the oxygen, and then placed into a handheld ATP luminometer. And you will get a digital result after the test. So what are some of the benefits of ATP testing? Well, again, it's a confirmation of the cleanliness of the surfaces, instruments, endoscopes, and your environment, thereby reducing the risk of cross-contamination between patients. You do have the ability to track and monitor your cleaning practices. So the devices can actually be programmed for different, say, instruments or instrument trays or endoscopes. It could also be programmed for different people who are doing cleaning. So for instance, you may have John, Jane, and Joe who clean instruments down in Central Sterile. And before being sterilized, they'll check the instruments that they've cleaned. And maybe Joe, for some reason, is always having higher than normal levels of ATP after he does cleaning. Or maybe he needs to be retrained. Maybe you need to look at the products he's using for cleaning. And you can look for trending. It's also a quantitative assessment that you get out. You get a digital readout, which can be used and downloaded from a computer for documentation. If, say, Joint Commission's coming in and they want to talk to you about, where's your documentation on how you're checking for cleaning effectiveness and cleaning. You can actually run reports right from the computer. But the biggest thing is that it's a quick and easy test. You will get results in as little as 15 seconds. So protein tests have gained popularity also recently. Unlike ATP testing, they have become easier to do with quick results, but will also only detect protein as a factor in residual contamination. So at the conclusion of the cycle, Central Sterile will determine if instruments are ready for use or if they need to be replaced or repaired. This is a nice ugly photo of some instruments that clearly need to be replaced. The Central Sterile technicians, on the front line, they face enormous challenges in monitoring the high volume of instruments they're seeing going by checking for blemishes, corrosion, anything that could impact patient safety. So how do you really know when an instrument is at its end of life? Some indicators would be, rust on instruments that cannot be resolved, or decreased functionality of instruments, corrosion on instruments, permanent stains that cannot be removed by stain removers, any cracks in instruments, again, decreased functionality, and instruments that have outlived their life and are no longer guaranteed, instruments that can no longer safely be used in surgery. So we mentioned earlier about equipment refurbishing. Let's talk about that for a minute. There are many third-party companies now that refurbish and repair instrumentation. Surgical instrument refurbishing is the professional process of restoring used surgical tools to like-new condition. And this can save hospitals a lot of money as it extends the life of the instruments. Now, the key processes in refurbishing include inspection and cleaning. That's the initial assessment of damage, followed by deep cleaning, usually ultrasonic, to remove bioburden. Repair and reshaping. They have the ability to fix broken parts, realign jaws, sharpening cutting edges, and grinding and polishing surfaces. And then refinishing, applying matte, satin, or mirror finishes to reduce glare and restore aesthetics. Lubricating and oiling, which would be applying specialized lubricants to stiff joints for smooth operation. Any special treatments such as gold dipping tungsten carbide rings for identification or electrochemical etching for labeling. But basically, the main thing is that quality control, rigorous final inspection, functional testing, and certification to meet OEM standards. They're getting these instruments back to original manufacturer standards. Now, the November 2025 AORN journal described some revisions coming to the guidelines for the care and cleaning of surgical instruments. I wanted to bring these up because there's some important changes that are going on here. So a new term has been described called gross soiled. Gross soil is defined as obvious tissue, blood, and other materials that can be mostly removed with excessive effort by flushing and wiping during or immediately after the use of the device. Regarding cleaning verification, AORN strongly suggests utilizing verification testing to support instrument cleanliness, such as ATP testing, carbohydrate, protein testing, hemoglobin, and endotoxins. They're not saying which one to use or which one is better, but they strongly suggest, again, using some sort of verification testing to make sure your instruments are cleaned properly. They also have a new recommendation on treating soiled instruments that have been allowed to dry. We mentioned earlier in the presentation that some of these instruments that are allowed to dry make it very, very difficult to clean. Now manufacturers are coming out with IFUs for delayed, they call it delayed reprocessing. So if instruments have been allowed to dry, they may have some special recommendations like using highly alkaline detergents to start breaking down and getting the dried bioburden off, extended soaking times and things like that. And for cleaning inspection, AORN strengthened the recommendations to use a clean borescope to visually inspect lumen devices after cleaning, basically looking for any damage, any soil, any debris, and things such as reusable suctions, reamers, cannulated reamers in orthopedic, arthroscopic shavers, anything that has lumens, to look for visible soil, and then again to use the other verification methods to support that things are truly clean. Some important takeaways from today. Again, cleaning of instruments begins intraoperatively at the point of use. That's the beginning of the reprocessing phase. Use of enzymatic gels, humectant sprays, keeping instruments moist, and start breaking down the bioburden is very, very important. Effectively cleaned instruments will reduce the risk of infection and increase the life of an instrument. We said the cycle is kind of like birth to end. Think about something more mechanical than a human body. It's like your car. You get your car, it's beautiful. You want to take care of it, you take care of it, you change the oil, and it will last you a long time. Again, not all surgical instruments are created equal, and testing methods for cleanliness have improved, expanded, and are quicker than ever. And again, recommendations from AORN, you want to use adjunct tests for maintaining and verifying that your instruments are actually clean before sending out for high-level disinfection or sterilization. So in summary, we discussed the instrument selection for purchase and initial sterilization. We described the use heavily into reprocessing and use of surgical instruments, and we identified methods for testing instrumentation for cleanliness. So thank you everyone who tuned in. I appreciate your attendance. I want to wish everyone a healthy and happy holiday season. Now we'll open the floor to some questions and answers, and I'll send it back to you, Linda.
Perfect. Thank you so much, Robert. We've got a few that have come in. The first one is, how can my OR staff be sure that instruments are sterile before using them on a patient?
Well, okay, so clearly you can't see sterility, and you just have to rely and trust and have faith in the central sterile process. Look for the tray locks to make sure filter paper is in place. There's no holes in the filter paper. The indicators have changed with the CSPD load number and date. That makes sense. Again, having trust and faith in the central sterile, their process, and look for any issues on inspection, any foreign materials, any rust, any corrosion. So you can have faith that Central did their part, but that's the importance of really looking at the instruments when you take them out of the tray before you start using them, looking for again any compromise, any foreign material, any rust, any corrosion that would indicate something's not wrong. Another thing also is we've had a lot of issues in the past too with left moisture and water left in the bottom of trays that were had not properly gone through like a drying cycle. So again, once you lift your tray out, check the bottom of the canister if you're using canisters to make sure that there's no water in there. Anytime there's water, that's considered something left over that really should not be there, and you should probably seek getting a new tray because it didn't effectively go through the sterilization process. Those instruments should be coming out dry.
On talking about trays, I've just had one that's come in and said, have you heard that the one tray has been FDA approved for longer storage up to 365 days?
Not familiar with it, but I'm going to write that down because I do want to look into that. It's the one tray.
One tray, yeah. It's a
Okay.
capital one and a capital T for tray, all one word.
I'm gonna look into that. I'm gonna inquire about that, but that'd be very interesting uh, to look at that and see why that recommendation is coming there. Because for me, I see trays on the shelf that have been sitting there for over a year, so that'd be good to look up the recommendations and the one tray. I thank you whoever sent that, and I'm going to look into that. Sounds very interesting. I love new technology.
Okay, someone's just actually commented saying they consider one tray as immediate use, not preferred for JC.
No,
So
okay, I'm
just
gonna
an
look
added
into that.
thing.
All right.
Okay, yeah. Right, another question here is if there is staining or foreign looking material on instruments in a tray, isn't it sterile and okay to use because it's been sterilized?
No. Simple answer is no. Recommended practices, standards state that any instrument in a tray should not be used, and new instruments should be obtained. Because if you see staining, if you see something that just looks wrong, I have one surgical tech who's like, we call her Eagle Eyes. She'll find something almost on every tray, and it's good to point out, especially where the hinges are on clamps and things like that. Those are typical areas where there can be wearing out. We showed the picture where if that outer protective corrosive coating is compromised, the iron from underneath is going to come out and start rusting. So um, again, I've seen it so many times that end up on trays and also things in trays. Oh, there was a pen in there or a hair clip, but it got sterilized. Isn't that okay? What about bone fragments on orthopedic instruments? Sometimes bone cement, unidentifiable things. Would you want the staff to use a questionable instrument, are you or a family member? But again, best to be safe. But again, recommended practices and standards say if something's not right, just get a new tray. Just because it was sterilized and met all the parameters doesn't mean that you should be using it. So, thanks.
Perfect. So would you recommend testing instruments before using them in the OR?
So this is actually a question that comes up a lot when I've done live presentations, especially about, biofilm and ATP testing and things like that. So although testing instruments with the different methods available like ATP, protein, and all that, you're using a testing swab. So if you open your tray of instruments and now you want to test it to make sure that it's clean, you're actually going to contaminate the tray because you're using a non-sterile swab. The testing methods are, bottom line, it's to evaluate the effectiveness of your cleaning practices. So when you have a soiled instrument, when you have a soiled scope, some sort of lumen device or cannulated reamer or anything like that, you're going to clean them, you're going to wash them, you're going to do everything by the manufacturer's IFUs, you're going to use your enzymatics, your scrubbing, your manual cleaning, and all of that, and rinsing. And at that time, when you're done, that's when you're going to do your testing to make sure the effectiveness of your cleaning practices. If you're going to test sterile instruments, you're going to end up contaminating them. So that it's not a good idea to be testing them. If you're interested and you don't have to use the tray and you're just like curious, you could do that. But for trays or instruments that are going to be used, definitely not should be tested. The purpose of these adjunct tests are for literally checking the efficacy of cleaning practices.
Okay, the questions are really coming in now, Robert. Now, if there is a contaminated instrument in a tray, is the whole tray contaminated? ARNN states that the entire tray is contaminated. However, our surgeons are challenging this, stating that they want only the instrument in question handed off and re-sterilized.
Okay, so I guess, my thoughts are, what's deeming that one instrument is contaminated? So we just assume that there's one instrument in the tray that has corrosion that's, clearly you wouldn't want to hand to the surgeon. And if that's the case, then the entire tray is considered to be contaminated. You wouldn't want to just pass off the one instrument. And, we are the patient's advocate as the nurses, and the surgeons may get upset while they wait for another tray. Clearly, we should be, checking these trays before the patient's brought in the room, but in emergency situations, you may notice something. But the answer is basically, if one instrument is considered contaminated, the entire tray is considered contaminated.
Perfect. So if a pan is brought into the OR while a patient is in the room, but not opened and remains unused, does this require reprocessing or can it be put back onto the shelf?
Great questions, all you folks out there. So there are different schools of thought on that. I'm not aware of any standards or recommended practices or rules or laws that say that it is. I will tell you that, there's plenty of times where, we have big surgeries, you're opening 30 trays sometimes, and Dr. So-and-so says he may want this. Probably the best practice would be to keep it outside the room if you can until he asks for it. But many times, the trays are in the room and available. And if remain unused, I will say that, we will put them back on the shelf. We do keep them away from the immediate surgical area, in a corner, on the bottom of a cart type of thing. But it'd be interesting to see if there's any recommendations. If anybody out there knows of a recommendation from an organization like ANSI, AME, OSHA, anything like that, that would indicate that it should be removed, that, I would be glad to see that. But I have heard different schools of thought on that, and I've had nurses who work for us who said the same thing. It's like, I don't want to bring it in here because then it's considered contaminated. But we've never seen anything that does say that if it's in the room and the patient has had surgery, that the entire tray is contaminated if left unopened.
Okay, I've got to comment and say, when in doubt, throw it out is my response. So
Again, that's probably from the previous question about, a surgery, an instrument that's compromised. And again, would you want that tray used on you or a family member? No, absolutely not.
No. Okay, another question here is it more difficult or a special process to clean trays with patients who have C. diff or history of HIV or drug addict patients?
So say the question again. Is it more difficult
or a special process to clean the trays with patients with C. diff or history of HIV or drug addict patients?
Not that I know of. Again, I'm not a central processing technician, but I know that really we don't treat instruments any differently in the process. If Central Sterile does, I don't think they do, but we're not notifying them when instruments were used on any of those types of patients. Guillain-Barré or mad cow disease, that's a whole different story where those instruments would probably have to be disposed of. But using universal protocol, universal safety, all instruments are treated the same and should eradicate all of those things. Whether it's used on a C. diff patient or somebody with some other sort of communicable disease.
Perfect. Another question here is, of all the steps in reprocessing that you described, which do you feel is the most important?
Okay, so well, if I had to pick just one, I'm going to say that the post-procedure point of use cleaning of instruments of gross soil, again using water, flushing, and the immediate application of enzymatic solutions or enzymatic humectant gels to start the breakdown process that we described, and keeping instruments moist. That would be my primary right there. Again, that's the beginning of the reprocessing cycle. I can't stress enough that how important that is. And in the cycle, it makes the job for the central sterile technicians so much easier to receive instruments that are moist. The enzymes are starting to break things down. And again, we never had any of this in the old days. We just solely revised on central sterile to send us back clean sterile instruments. We've learned so much over the years. As I said, the chemicals have gotten better, the processes, mechanical washers, manufacturers IFUs. It's just so much better. But that I feel would probably be, for me, the most important part. And we're a stickler on that in my OR also. It's like, make sure you're doing this. We actually will audit and track. Central will help us by auditing and tracking trays that come down, and they'll say, you didn't spray this tray, or keep doing a good job and all of that. So that's how important it is, for not just for us for getting back, properly clean, sterile instruments, but for them on their end to make their job a little bit easier. Which, when you talk about time constraints for getting trays back quickly, that helps save time also.
Perfect. Okay. Are any instruments more prone for causing SSI?
Probably, I can't say research. I can tell you my opinion on this only, but cannulated lumen instruments, which are so hard to clean effectively. Um, Flexible reamers, orthopedic reamers, arthroscopic shavers, things with lumens. I mean, when I think about, again, how many times have I mentioned the old days? Because I've been in the OR for a long time, but reusable suctions, which some people are still using reusable suctions. You think that that couldn't cause any harm if there's something in there because the bad stuff's being sucked away from the patient, but they looked at reusable suctions, and I think they tested 40 reusable suctions that had supposedly been cleaned and reprocessed, and they tested them, I believe, with ATP, and all 40, 100% of them had residual contamination in there. I know that for my OR, we're pretty much, I'd say 99% disposable suctions, but there are some special suctions that you still have to use, micro suctions for microsurgery, pediatric brain surgery, neurosurgery. There are still many reusable suctions is still out there. So those lumen devices, those cannulated devices, probably the most difficult to clean effectively. Again, following manufacturers' IFUs, for brushing, what types of brush to use, what types of chemicals to use, and again, the verification test to make sure that you did a good job. Endoscopes, on the other hand, too. I mean, when you think about the endoscopy suite and their scopes with suction channels, biopsy channels, water channels, all of these other channels going through them, very, very difficult to work with, the reprocessing of those scopes. And they do a good job.
Perfect. Right. Thank you so much, Robert, for another great presentation, of course, as usual. So if you'd like more information about today's presentation and sponsor, please visit ruhof.com. As promised, the answer to today's trivia question is Washington State. So congratulations to our winner, Raynon Villarreal in North Carolina. I apologize if I pronounced that incorrectly. Now, just a quick reminder, you can attain your CE certificates by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your certificates, and you'll be able to download the certificates directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Please visit ortodaywebinars.live for more details of all our upcoming webinars and, of course, complimentary registration. Now, just a quick reminder, if you've missed any of our past OR Today webinars, including any by Ruhof, you are still able to view them on our website, ortodaywebinars.live. So thank you once again for your time today, and I hope you'll have a great rest of your day.